I'm going to go ahead and get started this morning. Welcome back, everyone, to session 2 of our series on clinical considerations of substance abuse and critical components of proper prescribing. I'm so glad that you all can be with us this morning, and I hope that you're finding these educational sessions to be helpful and informative as it relates to your practice. Your participation in all of the virtual symposiums in this series will provide the 4.5 hours of CME required to meet the House Bill 1 requirement for licensure. CME credit will be issued upon receipt of your completion of the SurveyMonkey evaluations, which can be found in the Whova app under the Resources tab. You will also receive an email from KMA staff following these sessions that provides a link to the survey evaluation as well. We're very happy to be partnering with the Kentucky Board of Medical Licensure to provide these important educational sessions focusing on the clinical considerations of substance abuse and critical components of proper prescribing. We're extremely thankful for the support of the Federation of State Medical Boards Foundation, and the Kentucky Medical Association acknowledges the unrestricted educational grant from the FSMB Foundation in the amount of $10,000 to support this educational opportunity. Again, please remember to complete your post-activity evaluation in order to claim credit, and know that our CME certificates will be sent out to you via email, hopefully by the end of next week. I do ask for your patience as we have several hundred that we'll need to process, and I appreciate your patience in this matter. With that, it is my pleasure to welcome our speaker, Dr. Colleen Ryan. And with that, Dr. Ryan, I will turn it over to you.
All right.
As Dr. Ryan accesses her slides, for all of you in attendance, please know that you are able to access Dr. Ryan's handouts in the Whova platform, and she has provided those for you this morning in the documents section under the agenda. Dr. Ryan?
Okay. So thank you for inviting me this morning, and I hope you're all doing well. I'm here to talk a little bit about benzodiazepines, and I'm going to refer to them as benzos because I think that's the way most of us in clinical practice refer to them. Benzos, to me, have always been a really interesting class of medications, and people have very strong opinions about benzos. If you ask most clinicians, they'll sort of say, no, I don't really prescribe them. They're not good drugs. I've heard people say, I'll never prescribe a benzo, ever. So, you know, we kind of have this bad drug, good drug thing in the field of medicine. And I'm really not here to tell you that benzos are bad drugs. They do have their issues, but what I want to try to do is present a little bit more of an objective view of benzodiazepines. You know, I've been around for a while. I don't like to say how long, but really I've been practicing probably for close to 40 years. So I've seen a lot of trends in the field of medicine, and I feel like we sort of go through this, you know, wave of what's a good drug and what's a bad drug, like sort of like a roller coaster. Like, you know, for a while we'll prescribe a medication and, you know, it seems okay. And then something will come up, a new medicine that's better or some side effect. And suddenly the old one is like bad. We're never going to prescribe it. And yet a few years later, we end up, you know, it sort of comes back, maybe in a different form, maybe for a different indication. But so I don't really think of medication as bad or good. It's just a medication, and you have to know when it's indicated and you have to know how to use it. So even though benzos sort of have a negative reputation, they're very prescribed. And some studies actually say, now this is including all physicians, you know, not just psychiatrists or primary care. Some studies say that benzos are still the most prescribed psychotropic medication, which is interesting to me. So I think, you know, a lot of people, a lot of clinicians don't really like benzos. They feel kind of guilty about prescribing them, but they still do sometimes. So they're still prescribed because, frankly, they work. They do work. No study has ever shown that there's anything better than a benzo for anxiety. Now, they're not first indication anymore for anxiety, and we'll talk about that later, but nobody says they're not effective. It's just that obviously they have other issues that you have to be aware of. Why do people use benzos? You know, I think there's this perception, I've heard people say this, that if people are seeking benzos, they just kind of want to, you know, buzz out. They just kind of want to get high. They want to, you know, sort of escape from everything. That is true probably for some people. And we'll look at the statistics in a minute. Some people do use benzos to get high. There's no question about it. Some people try, and the biggest use of benzos in substance abusers, of course, is to heighten the effect of another drug, primarily opiates, or to come down, for example, from stimulants. But there are people who use benzos, frankly, because they're anxious. We have a lot of anxiety in our society, especially right now. We have a lot of anxious people, and I think sometimes we sort of dismiss anxiety. You know, it's okay to be depressed and be prescribed an antidepressant, but sometimes I think we minimize the impact of anxiety. There is morbidity associated with anxiety. So, you know, I think there are people who just don't want to be anxious, and I don't know that that's a terrible thing. I think there may be other ways to achieve that. Why not prescribe them more? Well, because they do have issues. You know, there's the issue of abuse. And we're going to go through some of those. They're somewhat complicated drugs to use. So just a little bit about epidemiology. So this is from 2008. So this is like 12-year-old data. And back then, about 5.2% of the population between the ages of 18 and 80 filled a prescription for benzos. And this was, the highest use was 8.75% in the 65 to 80 group, which is kind of concerning because that would be the group that probably is most likely to experience the negative effects of benzos. The lowest use was in the 18 to 35 age group. And basically what the bottom says is that of those patients who received a benzo prescription, from a psychiatrist, not a primary care person, it decreased from 15% in the 18 to 35 group to 5.7% in the 65 to 80 group. So basically what that is saying is that psychiatrists were not prescribing as many benzos. Only 15% of the benzos prescribed for 18 to 35-year-olds and 5.7% of the 65 to 80-year-olds came from psychiatrists. So this is another study. Investigators looked at data. This is a recent one. There's a study that the National Study on Drug Use and Health is done, I think every 3 to 4 years, and they look back at data from the previous years. So this is the one from 2015-16, more recent data. They looked at 102,000 adults. And what they found is that 12.5% of adults in the US use benzos, which extrapolated to about 30 million persons, but only 2.1% of US adults misuse them. Now, this is total US adults, and about 2% met criteria for benzodiazepine use disorder. So basically what this study is saying, and it does show an increase because if you remember from the previous slide, I think it was like 5.7% of adults had used benzos in the last year. And here, you know, a few years later, it's 12.5%. So there is an increase. But what they're also saying is that if you look at the big picture, only 2.1% of adults misuse them and 2% met criteria. I'm gonna move my slide here. 0.2% met the criteria for benzo use disorder. So in the big picture, not a lot, but it certainly is still there. And remember, benzodiazepine use disorder that's the DSM-5 criteria for basically what we call benzo addiction. And just to remember, you know, dependence on benzos does not equal addiction. In order to meet criteria for addiction, you have to have misuse, you have to have negative consequences. There are a whole set of criteria. It's not just physiological dependence. They also looked at why people misuse medicines, which we talked a little bit about. Why do they misuse benzos? And remember, their definition of misuse If you took one extra pill over the whole year, that counts as misuse. So there's kind of a wide range of, what qualifies as misuse. So among the past year misusers, of the subset of people who did misuse, 46% reported that they wanted to relax or relieve tension. They didn't want to be anxious anymore. The next highest was they wanted help with sleep. 5.7% reported experimentation as their main motivation. 11% reported using them to get high or because they were, hooked and they needed to continue use to avoid withdrawal. Oops, I'm having trouble advancing my slide here. Okay, here we go. So this is just kind of an illustration of the same thing. You can see that most people just don't want to be anxious anymore. But there's a subset that want to get high, the 11.8%, and, they're definitely there. I'm having trouble advancing my slides here. Sorry. Okay. Sorry. This is a different take on the same study. Same study, but what they're saying is, oh my gosh, 1 in 8 of US adults use benzos in the past year. So they're looking at a different standpoint. They're looking more at the idea that 17% of the people who use benzos misuse them. So just a different take on the same study. Okay. I'm going to skip this one because it basically says this. Well, basically what this one is saying is that then they looked at what are the most commonly misused drugs over the past year. So they're saying that they surveyed probably 270 some million people. 241.6 had no past month illicit drug use. This is past month. 30.5 million had past month illicit use. Most of the illicit use was marijuana. So they're still considering marijuana illicit. It's not legal in every state. That was number one. Prescription tranquilizers, which would be Valium, the benzos, ranked 5th. 1.7 million of the 30.5 million people who used illicit drugs used tranquilizers and sedatives, which would be the Z drugs, the sleep meds. That was 0.4 million. Okay. This is the problem with benzos. They're involved in 30% of opioid overdoses. And concurrent use of benzos and opioids increased by 40% in the last 12 years. This is data as of 2015. As of 2013, 20% of patients taking opioids also were taking benzos. I mean, that's a concern. On the other hand, sometimes you look at statistics and you have to know what the backstory is. I mean, these may have been people who had been on benzos for a long period of time. They may have developed some tolerance to the sedating effects, but still, that it's the concurrent use that I think most people are really concerned about right now. And this is CMS, and they did a study and found that 33.3% of patients who did not have cancer and were not in hospice filled prescriptions for opiates. So these are probably people with non-cancer chronic pain, and 24% of those had concurrently filled a prescription for benzos. So again, it's the concurrent use. And that's the study at the bottom, it shows that. Okay. Between 1999 and 2015, opioid-related overdose deaths nearly tripled, and 33,000 deaths were due to opioid-related overdoses. and 30% of those probably involve concurrent use of benzos. Of course, the main reason is that it's the combination of the depressant effects on the central nervous system. This is another one from Medicare, which is kind of interesting. They found that there was a 5-fold increase in the rate of overdoses. Now, this is not just with benzos, it's just overdoses generally in the first 90 days of concurrent use. This is concurrent use. So what they're seeing is that overdoses are more likely to happen early in concurrent prescribing. Probably maybe when the dose, is being adjusted. So I wanted to talk a little bit about Xanax, Alprazolam. You may not have this slide because I added this, but Alprazolam, interestingly, is, as of 2013 at least, was still the most commonly prescribed benzo and the most commonly prescribed psychotropic medication in the US. Now, that was 7 years ago, so maybe things have changed a little bit. I think people have become a little more aware of the issues with Xanax. The median length of stay was 19 hours in the ER when Alprazolam was involved, which means it might not have been the only drug, but it was involved with the overdose. And it's 1.27 times longer than other benzos, and patients were twice as more likely to be admitted to the ICU if Xanax was involved. So Xanax, for a lot of reasons, I'm not sure why, it's one of the later benzos that came on the market. It's really not any better for anxiety than the other benzos. In the beginning, it was marketed as possibly being effective for depression because it does have a triazolo ring. So it has some pharmacologic features that are a little bit similar to particularly the tricyclic antidepressants. But really, and some studies have shown that it can be helpful with depression. The problem is they're not good quality studies. They're short term, and it may be that what's happening is that the Xanax is kind of relieving the anxiety component of the depression. Down the road, nothing has really shown that Xanax is helpful for depression. I mean, if you have somebody with depression, you need to be treating them with an antidepressant. There aren't a lot of studies. It's just not many studies comparing Alprazolam and SSRIs as monotherapy for anxiety. There actually are some studies that are probably more recent than 2013 that show that benzos are probably in some ways superior to treating anxiety than SSRIs. But again, the issue is the side effects, all the issues that benzos have, and the fact that SSRIs are not lethal in overdose most of the time. Xanax has some unique pharmacologic properties. It has a shorter onset of action, which makes it more likely to be abused. People get a kick from Alprazolam that they really don't get from a lot of the other benzos. And so, they get that sense of being a little bit high and relaxed. And so that makes it a more abused benzo more than any of the others. It's high potency, but it also has more severe withdrawal symptoms after a shorter period of use. It has more dopaminergic function than some of the other benzos. And so you can get a little bit more excitation with Xanax, which seems a little contradictory, but that's where I think you can get sometimes the disinhibition that you can see with benzodiazepines. The Alprazolam withdrawal syndrome is unique. The discontinuation syndrome is longer and more severe even when tapered, and there's a lot of rebound anxiety. That's always the issue when you're trying to detox somebody from benzos. They were anxious to start with, and so it's very hard to tell sometimes whether they're getting a rebound of their original anxiety or whether they're having withdrawal symptoms. In a study with combat-related PTSD, this is a small study, obviously. They had 8 patients. They treated with an average dose of 4.6 milligrams of Xanax. They noticed worsening sleep disturbance, nightmares, irritability, hyperalertness. 6 had dissociative reactions. or let's see, I got to move this little thing here. 6 had rage reactions and homicidal ideation, and 4 had dissociative experiences. So I think we figured out in psychiatry that you don't use benzos for people with active PTSD. Now there's chronic, a more chronic form of PTSD, which is really more, anxiety, difficulty with relationships. But people who have nightmares, intrusive thoughts, the hyper alertness, especially combat PTSD, benzos usually they don't do well on benzos. They're more likely to have the disinhibition and, the rage reaction. So I would definitely avoid benzos and particularly Xanax with those people. So the bottom line is, if you're going to use a benzo, Xanax, there's really no good reason to use Xanax. It's just more complicated and has many more issues. Okay, so this is the other reason that we're here, to talk a little bit about House Bill 1 and some of the regulations about prescribing controlled substances. So this is from KAR 9260, which is these are the regulations about prescribing controlled substances in the state of Kentucky. This is section 7, okay? Professional standards for the prescribing and dispensing of controlled substance for the treatment of other conditions. So most of the rest of the sections are talking really about prescribing opiates, pain medicines. So now they're talking about somebody who has a condition other than pain. So it says, before initially prescribing or dispensing a controlled substance to a patient for a condition other than pain, the physician shall, this is common sense stuff for the most part, obtain an appropriate medical history relevant to the complaint. If it doesn't relate to a psychiatric condition, conduct a physical exam, and the usual stuff you would do of the patient relevant to the medical complaint. If the complaint relates to a psychiatric condition, perform or have performed by a psychiatrist or other designated mental health provider, an evaluation, get a consult appropriate to the presenting complaint, and document the findings. Also, it says obtain and review a CASPER for the 12 months prior. So you've gotten your consult. It says, after examining the benefits and risks of prescribing or dispensing a controlled substance to the patient, including non-treatment or other treatment, make a decision. Is it medically appropriate to prescribe or dispense the controlled substance? Now, they don't say it. I think what they're talking about, it probably is more, benzos in this case. If you decide to prescribe, avoid providing more controlled substances than necessary by prescribing or dispensing only the amount needed to treat the complaint. Do all the things you normally do, explain that a controlled substance has limited use, talk about proper storage, and discontinue use as soon as you can. I think what a lot of people prescribing pain meds at this point really do is feel like the patient should be referred to a psychiatrist or mental health professional if you're prescribing pain meds and that you feel like they need benzos or some other form. If somebody has such severe anxiety at that point, you're probably, and you have tried the non-controlled substance stuff like SSRIs, it probably is better to refer. The problem I know you're going to say is, well, how do I find a psychiatrist or a psychiatric nurse practitioner? And I know that's an issue, but at least get a consult and document that you got a consult. This is if a physician receives a request from an established patient to prescribe or dispense a limited amount of a controlled substance to assist in responding to anxiety or depression. Again, obtain a CASPER, make a decision that it's medically appropriate. If it's medically appropriate to prescribe, then prescribe the minimum amount. And I think somewhere it says that you can do that for 30 days before you have to get a consult. That's kind of in an emergency situation. Now this one, well, this again, if it's not working, you have to continue to evaluate it. If it's really not working, then stop prescribing it, taper it off. Okay. Now this is the regulation for prescribing, for people prescribing buprenorphine products. And what it says is, I'm looking at Part B at this point, a physician may prescribe or dispense buprenorphine monoproduct or buprenorphine combined with naloxone to a patient who's also being prescribed benzos, other sedative, this is the 30-day one, other sedative, hypnotic, stimulants, or other opioids without consultation in order to address an extraordinary and acute medical need not to exceed a combined period of 30 days. So this is a 30-day one. This is if you're prescribing buprenorphine and you feel for some reason the person needs another controlled substance. I mean, again, there are a lot of other options before you get to that point. But if you really feel that, you can do it for 30 days. But after that, you need to get a consultation and refer. So just a little bit about pharmacology, because I think it does help you understand how benzos work. This is the GABA receptor. Benzos primarily have the effect of stimulating the GABA receptor. And that's, of course, GABA is the inhibitory neurotransmitter in the brain and opposes glutamate, which is the excitatory neurotransmitter. So this is the GABA receptor. The interesting thing about the GABA receptor is that it's made up of subunits. It's made up of 5 subunits, 2 alphas, 2 betas, 2 gammas. Now, they're different because it says alpha 1, beta 2, gamma 2. That means there are different, groups of these subsets of the alpha receptor. So there's more than alpha 1. There's alpha 2, 3, 4, 5. There are more betas. There are more. So you can get a lot of different combinations. You can get different GABA receptors that have, it might have alpha 2, beta 2, it might have alpha 3. So you can get a lot of different combinations, and different benzos prefer different alpha groups. And it's primarily the alpha group that really makes the difference in the, efficacy and what the benzo exactly does. So in that way, all benzos are not alike. The interesting thing is the benzo doesn't bind to the GABA site. You can see on there that there is a site where GABA binds. GABA binds to the receptor. Chloride is released through the chloride pore. But benzos don't really bind to the GABA site. They bind to a site between alpha and gamma. And what they do is change the conformation of the GABA receptor so that GABA has more affinity for the receptor. So it's an indirect agonist, basically. This is the most common arrangement, the alpha 1, beta 2, gamma 2. The second most common is alpha 2, beta 3, gamma 2. So that just tells you how many different subunits there are. Benzos act as indirect agonists. This just tells you how many different combinations of these subunits you can find and where they are in the brain. Just a little reminder, an indirect agonist doesn't bind directly with the GABA receptor. It binds elsewhere but changes the conformation. A direct agonist binds directly to the GABA receptor. Gaboxidol is an example of a direct agonist. Flumazinil is a competitive antagonist. Flumazinil is used to reverse the effect of benzos. And it can be used in a benzo overdose. The problem with flumazinil is if you have somebody who's really dependent and they've developed a physiological dependence on benzos, when you use the flumazinil, you better be prepared because there'll be an immediate severe benzo withdrawal. And there's the chance of seizures. So, you have to be very careful about using it and realize what you may have to deal with when the person wakes up. Yeah, I don't think these others we need to go through. So this is the interesting thing. Some benzos have preferences for certain types of GABA receptors, like zolpidem, Ambien, has a specific preference for the alpha 1 beta 2 subunit. The alpha subunit really is the one that seems to determine what the benzo, the affinity. Stimulation of the alpha 1 or 5 subunit is more likely to produce sedation and anterograde amnesia. The alpha 2 or 3 subunits seem to have more anxiolytic effects. So theoretically, if a benzo prefers the alpha 2 or 3 subunit and not the alpha 1, you should theoretically get more anti-anxiety effect and less sedation. If a benzo, also the alpha 5 subunit has more to do with memory and learning. So things that bind to the alpha 5 subunit or prefer the alpha 5 subunit are going to have more of the memory issues. Diazepam prefers the alpha 2 or 3 subunit, while lorazepam prefers the 1 or 5. So, theoretically, you could engineer benzos to prefer certain subunits and maybe minimize some of the negative effects. Okay. So again, zolpidem prefers alpha 1. Tolerance to the anxiolytic effects of compounds selective for alpha 2 and 3. This is in a study, did not develop. So basically what they're saying is, I think we've all had the perception that after you use benzos for a while, they're probably not really helping that much with anxiety. You're just maintaining the dependence. I think that has been a philosophy. That may not be totally true. For the ones that are binding mainly preferring alpha 2 and 3, you are still probably getting an anxiolytic effect, and tolerance is not developing as much. Let's just skip that one. Again, pharmacokinetics. Most benzos undergo hepatic metabolism mediated by cytochrome P450. It's CYP3A4 is the common subtype. So obviously they're going to be affected by anything that induces or inhibits CYP3A4. The other issue with benzos is that a lot of them have active metabolites that are slowly cleared, such as diazepam. Diazepam has 3 active metabolites, and they hang around for quite a while. After they're metabolized by CYP3A4, they undergo conjugation with glucuronide. But the interesting thing is that lorazepam and oxazepam are parent drugs. They undergo direct glucuronidation. They do not go through the cytochrome P450 system, and they don't have active metabolites. So they are less subject to drug interactions or reduced clearance for people who have hepatic dysfunction. I know this is very difficult to see. If you really want a good copy, you can send me an email and I'll get you one, but it really just is a chart that shows you the half-life of most of the benzodiazepines, and you can really get a sense of how variable it is. It also shows you the active metabolites. Excuse me. The interesting thing is you have to think about this when you're getting a urine tox. So for example, if you prescribe diazepam to somebody, and your office little point of contact testing will probably just show a benzo, so you send it off for confirmation testing. Confirmation testing is really going to tell you what the metabolites are. Now that's useful if you want to check and see if somebody might be selling what you're giving them and using a different benzo. But what you have to be aware of is if you gave them Valium, diazepam, it's going to break down to temazepam, oxazepam, and decimethyldiazepam. So you get your results back of your urine tox, and it says oxazepam and temazepam. You may think they're taking a different medication, but they're not. It's just that the diazepam breaks into those metabolites. And a lot of the benzos break down into metabolites of other benzos. So you have to be aware of that when you order a urine tox. The Z drugs, a lot of people are talking about the Z drugs. They're newer. It's zolpidem, Zaloplan, some of those. They basically bind at the same site that benzos do. They're similar to benzos. They're a little more selective for the sedating function. So they're a little more selective for the alpha-1 subunit. So their effects on memory should be less pronounced, and tolerance should be less likely to develop to their pharmacologic actions. They still have their issues. They do, but they're a little less tricky than benzos. There's still concern over long-term use, development of physiologic dependence. Again, Xanax and Valium both have rapid onset of action and higher abuse liability. They're not as protein bound, that's the other thing. These are, again, reasons why somebody might move from just using benzos as prescribed to addiction. It's the hedonic effect, trying to combine with other drugs to get more of a high, the development of tolerance and the need to escalate the dose, though again, that isn't over the board true with everybody using benzos, and avoidance of withdrawal. There is a phenomenon called post-acute withdrawal, which happens with other drugs as well, but it's known with benzos where even if you slowly taper somebody off a benzo, they can still have just some, symptoms of irritability, hot flashes for a while afterwards. They're usually low-level symptoms, but they can be there for several months afterwards. Some people say memory issues can last for a while, several months afterwards. We're going to talk a little bit about the memory issues in a minute. These are some of the common reactions. I think most of these. They're in, the pharmacologic databases. Some of the ones that you're concerned about are aggressive behavior. It's not common, but it can happen with benzos. They can have a disinhibiting effect. Stevens-Johnson syndrome, you really wouldn't think about with benzos, but it has occurred with Xanax. The elevated LFTs, hypotension, which is the big issue, especially in older people. Urinary retention, impaired concentration, those are the ones you want to look at mainly. Okay. Again, the most serious interactions are when benzos are combined with other drugs, and especially medications that are metabolized through the CYP3A4 system. Common inducers of CYP3A4 would include rifampin, Tegritol, phenobarb, dilantin. So, of course, the inducers mean that you're going to have more of the CYP3A4, so it's probably going to chew up the benzo more quickly. Inhibitors means that the benzo will not be metabolized as quickly, and you're going to have more drug available for the most part. So benzos in memory, this has been a big issue, and I think one of the big reasons that people have concerns about benzos. So this is from an article that came out in June of 2020 in the American Journal of Psychiatry. Now, this is an opinion piece by Carl Salzman, and it was based on a study, a meta-analysis that was in that issue. So this is what he says. Clinical experience, as well as a retrospective meta-analysis, suggests that any related memory impairment is primarily recent recall and is often mild and largely reversible when benzos are discontinued. These effects of benzos may be due to interference in usual GABA benzo chloride ionophore function or individual sensitivity to these drugs, especially in elderly individuals who may be more susceptible to side effects. So he's kind of minimizing the memory issue, which is sort of not what we've been thinking, I think, for the last several years. This is the actual study that he's referring to. It's done by Osler and Jorgensen. And again, it's in the June issue of the American Journal of Psychiatry. I'm not going to read this whole slide, but basically these guys have done a lot of research with benzos. They did a meta-analysis. They were looking at, and what they said is that a large cohort study did not reveal associations between use of benzos or Z drugs and subsequent dementia, even when exposures were accumulated or divided into long and short-acting drugs. So back around 2014, studies started coming out suggesting that benzos might lead to dementia. there was an association between use of benzos and dementia. I think probably one of the first studies came out of France. So everybody started saying, oh, benzos cause dementia. Well, those studies have kind of subsequently not been replicated. There were some issues with how they selected patients, people, how they selected subjects for the study. Basically, they selected, it was a retrospective review, I think, and they selected based on prescriptions for Aricept and the dementia medications. They didn't really control for substance abuse, some of them. And, the bottom line with dementia is that it's hard, it's hard to know what comes first, because signs of dementia can start developing even 10 to 20 years before people are actually diagnosed. So does it mean that those people are kind of sensing that something's not right, and so they're more anxious? It's hard to know. It's a good example of how association does not necessarily mean causation. So, we're not saying at this point, is there an association? I think we need to do a lot more studies, but we're not seeing that there's necessarily a causation. Okay, and that's just, again, some more references from that paper about this study. The issue with respiratory drive is that benzos decrease central respiratory drive and the chemoreceptor responsiveness to hypercapnia. They decrease arousability for sleep, so that you can have longer periods of hypoventilation and aspiration. And they may also affect the pulmonary musculature by activating Gaba receptors that are located in the peripheral nervous system, and that can decrease inspiratory and expiratory respiratory muscle strength. And they also can exert effect, they're muscle relaxers. So they're going to relax some of the muscles of the lower esophageal sphincter, and you can get reflux and aspiration. And they may have some effects on the immune system. So it is recommended that you avoid them. They're pregnancy category D. They are excreted in breast milk. I know when I was first starting practice, benzos were an absolute no-no in pregnancy because of cleft palate. They're still really a no-no, but the association with cleft palate is really not as clear. There is some concern possibly about later associations with gross motor skills and communication deficits, but it's really hard to tell with late associations. There's so many confounding factors, but the cleft palate issue doesn't seem to be a major issue. But I would really have concerns about prescribing benzos to somebody who's pregnant. For one thing, especially if you've got a woman on buprenorphine, there is neonatal abstinence syndrome, even with buprenorphine. It's usually less than with methadone or with street drugs, but it's there. And any other medication that they're on, benzos, even SSRIs, can increase the intensity of neonatal abstinence syndrome. So I think it's, pretty wise to just avoid benzos in pregnancy. There are some acceptable uses. They are anticonvulsants, especially for somebody in status epilepticus, short-term insomnia, pre-procedure sedation, short-term use for anxiety. What does short-term mean? Probably a couple of weeks. The problem, I think, is that a lot of us start out intending to prescribe them short-term, and then it's hard, because the patient wants to continue them. Catatonia, for those of you who remember your psych rotation or your psychiatrists, they're very useful, amazingly useful for people who are catatonic, and detox from alcohol. These are the APA practice guidelines for treating anxiety. People who want benzos are wanting them because of anxiety. They are second or third line for the treatment of generalized anxiety disorder and panic disorder. The recommendation is to use SSRIs or SNRIs first. You know, part of the issue is a lot of patients, I normally start with really low doses because people with anxiety are really, they interpret a lot of bodily sensations as anxiety. And you do sometimes with SSRIs get just a little bit of an excitation or a stimulation when you first start them. So I start with a low dose and try to, you know, get people to stick with them for a while, because that normally does go away. But that is one of the main reasons that anxiety disorder patients will tell you that they didn't like an SSRI. Usually the dose might have been too high or they didn't stick with it long enough. Some people do use benzos for that reason in the beginning to kind of mitigate that excitatory effect in depression. You can do that, but again, it's usually just meant to be short term. If they're having trouble sleeping, a lot of times with the SSRIs and SNRIs, they interfere with sleep in the beginning. So some people will use a little bit of a, you know, a benzo at night for the first few days, week or so. Don't use them in bipolar disorder. Usually there's no good reason to use them in bipolar disorder unless, you know, of course, people who are bipolar can have other disorders like generalized anxiety disorder, but that's complicated and probably should be managed by a psychiatrist. Sorry, my slide's not always wanting to advance here. There we go. So if you decide after everything that, you know, you've tried everything else and you want to use a benzo, again, document the reasons. But the big issue is that you have to assess for risk of addiction, because it's one thing to use a benzo in someone who's not, you know, abusing substances. But when you've got somebody who's abusing substances, it's a whole different ballgame. And you really, you know, that's where you really have to be careful. Part of the issue with benzos too is even when they're prescribed appropriately, they end up being available on the street. Why? They just seem available. People sometimes will turn to them when they don't have heroin. Not that it's going to help, but you know, when you don't have heroin, anything is better than nothing. Why are benzos so available? It's, you know, I think sometimes we're just not as careful as we should be in prescribing them. You have to treat them as a controlled substance. They are a controlled substance. They're Schedule 4. But they are controlled substance, and you have to be just as careful with benzos really as you would with prescribing opiates. So first of all, assess for the risk of addiction. Now, is somebody going to be honest about their history of addiction? Maybe, maybe not. There are tools that can help you. And actually, if you look at the KBML website, and I'll show you what it looks like at the end, there is a section that says prescribing controlled substances. And if you go to that at the very bottom, they have a lot of tools that you can use to assess for risk of addiction. The opioid misuse tool, which actually works very well for benzos. You can just substitute benzo for opioid. It works very well. There's some others there. The other thing is check a urine tox, because people are not always honest. So check a urine tox. And again, treat it as any controlled substance. You really need a consent form outlining the rules. They're not to get it from anybody else. You're going to be checking the Casper. I wouldn't do refills initially. I might just do a couple of weeks supply. They have to be seen on a regular basis. You can't just give people, you know, 2 or 3 refills, and that's how it ends up on the street. You know, people go in maybe one day early. Some pharmacies will go ahead and give it to them. They end up over a period of time accumulating a few pills. Or, you know, the common one is you maybe prescribe it 2 or 3 times a day. So they use 2 times a day and give the other one to somebody else. I would check pill counts, have them bring their medicine in with them to the appointment and check the pill count. And evaluate efficacy. I mean, if it's really not working, it's time to move on to something else. Check the Casper. This is the opioid risk tool. Very easy to use. It gives you a score. Your office staff could actually do this. The patient It's probably not one that you would want the patient to do, but your office staff in the triage section could do it. This is the prescription drug use questionnaire. Again, these are available on the website. And this is for people who are already prescribed pain pills or some sort of controlled substance. Again, say prescribing, same kind of thing. Just be careful. Don't give a lot, don't give refills unless the patient has been on the medicine for a while and you've really gotten clean, expected urine results. And then you might consider giving a refill. Try to make it short term. And remember, there are many other treatments for anxiety. It's getting people to do it. I know it's hard when you tell them to go exercise, but there's very good evidence. Exercise helps with anxiety. Therapy, CBT, is just as effective for most people, unless it's a severe anxiety. Sometimes having access to therapy can be difficult, but there are a lot of good therapists around. And, before you go to a benzo, I would definitely refer somebody to therapy. If you really don't have access for a therapist, there's a lot of stuff online right now. For a long time, I've used a series of books called Treatments That Work. And they're workbooks, and they have them for anxiety, they have it for panic attacks, alcohol use, just a bunch of self-help books. They're really based on CBT, and they're very helpful. And anybody can have access to them. They're not free, you have to buy them, but they're helpful. And again, SSRIs and SNRIs are really the first line, and they do work for a lot of people if you can get them to stick with it. There is Buspar. A lot of people think Buspar doesn't work well. I've had people have success with Buspar, although I will say that if they've been on benzos before, they don't adapt to Buspar as well. I sometimes use low doses of quetiapine, like 25 milligrams, even have them cut that in half. Vistaril and trazodone and mirtazapine have been used. Now, these have their own set of side effects, true. There's no medicine without side effects. We do worry a little bit about driving with people on benzos. Again, I think it depends on the kind of benzo they're on, the half-life of the benzo. You do have to warn them about that. But again, Vistaril can be kind of sedating. So I think that's true with a lot of medicines. Again, you're making a commitment to the patient when you put them on a benzo. Just real quickly, I didn't include the slide about benzo withdrawal. Don't stop them cold turkey. I think you know that. Seizures, delirium. The best way to taper somebody off a benzo is to just taper it. Do it slowly. There's no big rush unless they're on a high dose that you're really concerned about. Just taper them off. Even use the medicine they're on. You don't necessarily have to switch. You can. Now, a lot of people switch to Klonopin because it has a longer half-life, and it really does not have the kind of euphoric effect that the other benzos do. I use Klonopin a lot to taper people. And usually if they're on a high dose, it's easier in the beginning. It's easier to taper down in the beginning, and then when you get down to the lower doses, you a lot of times have to go more slowly. You might even have to just kind of hold for a couple of months and then resume. You can add some adjunctive medicines if you really need to. Now, what people a lot of times overlook is you can use Tegritol to detox people off of benzos. A lot of times this is started inpatient, but you could do it as an outpatient. You do, of course, have to watch the CBC. You've got to still continue the benzo for 3 to 5 days before stopping it because it takes a while for Tegritol to really kick in. Tegritol is kind of sedating. That's the main limiting factor that I have seen with Tegritol, but you can do that. Now, you do have to taper the Tegritol as well. And I usually would keep them on the Tegritol. I'd taper it over 4 to even 6 weeks. Okay. So again, benzos are not first line for anxiety. Their main issue is when they're combined with other drugs and the fact that people we're not careful and they end up on the street. and you need to follow KBML regulations and monitor closely. This is the website of the KBML, and if you look down at prescribing substance abuse and click on that, you will get this, and it shows you here the screening tools and resources. If you have any questions, I have my email address at the very end. And this is a quote from Jared Rosenbaum, again from the June American Journal of Psychiatry. And he says, benzos are medication. They're intended to be prescribed by those trained in how and when to prescribe them, how to weigh risks and benefits. And they're intended to be prescribed to address suffering, distress, and functional loss from psychiatric symptoms and disorders. They're one of many tools available, and they're not perfect, but I would not say, that I would never prescribe them. You just have to know when and how, and that's all I have.
Dr. Ryan, thank you so much. We do have several questions that have come in, and I don't know that we'll have time for all of them, so we may have to get with you offline for a few responses. But if you're okay with it, are you open to a couple of questions?
Sure.
All right. Thank you so much. So the first question comes from Dr. Tolbear, and he does have a two-part question, but for the time that we have today, he asks, I typically don't start chronic benzos. I use them only for acute situational anxiety, death of a loved one, fear of flying, etc. Does that require a psych consult?
I would say no, as long as you have done some assessment to make sure there's not substance abuse happening. I would still do a urine tox though, in the beginning and periodically, but no, that should not require a consult, especially, if you're using it short term.
Okay. Dr. Bowman asks, I have a patient receiving benzos from his ENT for vertigo. Is this an acceptable use?
Gosh, I have not heard of use for that, so I would kind of question that. I mean, I wonder if there's more to it. Maybe the person has some underlying anxiety, but I frankly have not heard of using benzodiazepines for vertigo.
Okay. Another attendee asked, I have a lot of patients who tell me that they are prescribed benzos for sleep by their primary care physician or psychiatrist. Can you comment on the use of benzos for sleep?
I agree that it's still somewhat controversial. If you're going to prescribe one, I would try to use the newer medications. Whether or not a benzo, again, I would not use a benzo first line for sleep. Sleep disorders are a whole other ball game, and a lot of the studies show that really therapy works for sleep disorders just as well as medication. The problem is access to therapy. I would try a lot of other things. Again, there are some online resources for people who are having trouble with sleep. I might try some trazodone or mirtazapine, 25 milligrams of Seroquel, because they don't have the dependency issues. But if you go with a benzo, I have occasionally used some Klonopin. The Z drugs are out there. Whether they continue to work long term is, again, you have with the sleep drugs, that is where you have to think a little bit more about issues with driving the next day. So I'm not saying don't use them. I would try other things first, but people want sleep. People want sleep, and that's a big issue. And I don't think it's the end of the world to use a benzo for sleep if you've tried a lot of other things.
Okay. One last question, and again, I know that our audience had several questions, and I really appreciate all of the engagement from the audience, and we will work with our speakers to try and get some answers for you on all of your questions. But for our time today, I'll ask one more question, Doctor, and the question is, why are there two levels of dosage in package inserts for Xanax, a low one for everything except for panic disorder?
Well, I guess, I don't use Xanax, so I didn't really know there were two doses for package inserts. I don't really know why that would be, because if you are using it for panic disorder, again, I would probably choose another one. But if you're using Xanax for panic disorder and somebody is using it only when they're having a panic attack, that's probably, you know, as long as they're not using it every day, they're probably not going to develop that same dependence. I have found that you can use low doses, especially if they're naive to benzos. You know, there's no reason that you can't start out with 0.5 of Xanax. So I don't really know why you would go to a higher level for panic disorder, because the lower doses can work just as well.
Okay. I know that we do have several other questions in the chat box, and I will submit these to you offline, but in the interest of time, we'll conclude today's presentation. Thank you so much for being with us this morning and taking time out of your Saturday to deliver this important information. As I said, I can tell from all of the engagement that this is something that physicians are interested in, and I appreciate all that you've given us today. So